Hello. Oh, there's Fatima.
Hi, everyone. Sorry, I'm having connection problems. I'm joining from my cell phone right now. So it's fine. Thank you, Simone, for joining us. I'll do the introductions. Thank you for wanting to go ahead. And I think just for the sake of time, we'll do a quick introductions and we'll get started on it. And I'll try and see if I can sort out my connection better as well. Okay. So welcome, everyone. My name is Fatima Ismail. I am the Senior Clinical Psychologist at Lentegeur Psychiatric Hospital, part of the Division of Psychotherapy, Division of Intellectual Disability, and part of the Department of UCT. So today we are wanting to speak about women because it's Women's Month. And I think that as a general kind of, I think we are known to always be speaking about gender-based violence. And I think today I'm so pleased to speak a little bit more about extending that term to obstetric violence. And so with us today, we have Associate Professor Simone Honikman, who is the founding director of the 21-year-old Perinatal Mental Health Project. And Simone has an extensive autobiography, and just a little snippet that she is, based at the Center for Public Mental Health, University of Cape Town. She's a medical doctor with extensive experience in pediatrics, obstetrics, and gynecology and psychiatry. And she's got a master's degree in maternal and child health. And some of her topics include gender-based violence, health economics, musical interventions, which is very interesting, and mobile training applications, which is the first time that I'm hearing about this, Simone, so I'm very interested. And with her, she's supported by her colleague, Tyla Prinsloo, who is a registered counsellor. She has her honors in South African, she's got her honors at the South African College of Applied Psychology. You can see I'm a bit all over the place at the moment because I've been rushing to get from one place to another. Okay, so she's currently working as a mental health counselor at the Perinatal Mental Health Project's clinical services site at the Hanover Park Midwife Obstetrics Unit. And her work includes tailoring mental health interventions and working to the needs of pregnant and postnatal women. So I'm not going to go into further information because we have sent out this, and so if you'd like to make more contact with both of these, you can find out a bit more information and also on their website. So I'm going to hand over to Simone to go straight into telling us a bit more about obstetric violence. Thank you. Simone, I think you are still on mute.
You're muted, Simone.
Okay, is everybody seeing my full screen? Or are you seeing the notes section? Tyler, if you could just... Are you seeing the full screen or
I don't see your slides yet.
Not at all. Okay. Let's just try again. I'm going to excuse the delay. I'm going to share my screen first and do that. Share. Okay, and then we're going to do this. Okay, this should be good. Everybody see the full screen?
Yeah, there we go. It's showing now.
Thank you very much. Yeah, thanks, Fatima, Naima, and the department. It's great to be able to share with you some work we've been doing over the last couple of years and where we've got to, particularly our secret history mobile application called SHiMA and the feasibility study that we've conducted, where we've tried to use stories to address obstetric violence. And we'll walk you through a little bit about the background to developing this mobile application. What is obstetric violence, why we need to locate it within the context of gender-based violence, what is the secret history, how did it morph from a face-to-face training that we've been doing for many years at PMHP onto a mobile app, how we did this transformation onto a mobile training app, and then some of the feasibility study results, which I will discuss and share with Tyla, who's been a big part of this process all the way along. So what is obstetric violence? Some people call it disrespectful maternity care, and there is a debate around which term may or may not be appropriate. I don't want to go into that debate right now, but need to describe that this is both a global and a South African problem. It covers disrespectful care to women during pregnancy, even prior to pregnancy, during the labor and birth of that, and also in the postnatal period. And it encompasses physical disrespect or violence, emotional disrespect and violence, and structural disrespect and violence. And those are the kind of three broad overarching categories. Physically, a woman may be forced into procedures that they haven't consented to, they don't fully understand. Women may be beaten, pinched, slapped. Emotional violence includes belittlement, includes women who are left to labor or give birth to their children on their own, threatening language, blaming language. And the structural violence that we refer to here refers to the violence that is meted out against women as a result of systems issues which are dysfunctional. For instance, a lack of privacy, a lack of access to evidence-based care, a lack of access to supplies that are required to have a safe, clean, and private maternity care experience. These problems are ubiquitous. There have been several studies that have been conducted. They seem to be linked to systemic forms of oppression, and here the gendering of this kind of violence is important to understand. But we also need to appreciate that these forms of oppression are also linked, particularly in South Africa, to our inherited the inherited forms of oppression that still today inform our health service. Secondary to apartheid legislation about who could not enter certain workforce streams. Nursing was one of the few professions open to women of color in the apartheid regime. Both the medical and the nursing systems still operate with a flavor of hierarchy, and often with this comes oppressive forms of behaviors. Inequities in delivery, inequities in service delivery, in service access are also systemic forms of oppression and which underpin this problem. It's linked, and this is linked as well to the idea of oppression within our system, excessive staff workloads and long hours, and a lack of mentorship and support. There also seems to be a focus away from empathy and connection, and more and within our health systems, there is more a reactive response to trauma, to adversity, and this also underpins this problem that we are facing in our system. Megan Boren is one of the key scholars. She and her team have worked across the globe looking at disrespectful maternity care or obstetric violence. It is a form of gender-based violence that's been formally recognized by the United Nations Human Rights Commission in 2019. It was formalized within a report on human rights-based approach to mistreatment of obstetric violence. And our appreciation of the gendering of this is important today within August month, Women's Month, whereby this definition from this chapter that I've recently come across is quite useful to understand. Obstetric violence follows, and I'm quoting, and obstetric violence follows and perpetuates the devaluation and subjugation of women in patriarchal societies, where socio-cultural conceptions contribute to a view of the female body as faulty. These shape the perceptions that female reproductive processes require technological corrections. I'm paraphrasing here. The entrance of women into the workforce and specialized fields, the feminizing care professions, have failed to shift this paradigm. Female health workers are trained in the procedures instituted by dominant patriarchal structures, expressing values encoded in the professional culture and institutions where they work. As women conform to the models they are exposed to during their training, perpetuating corporate hierarchies and practices, they act as agents and perpetrators of obstetric violence. And thus, this is a form of gender-based violence. I'd like to just introduce you to The Secret History. This is a theatre-based training project or initiative that we developed at the PMHP as long as 20 years ago. When we started to integrate mental health within maternity care services, we realized that we were working in a situation in which the culture was one quite often of disrespect and abuse. And we realized that any attempt to integrate mental health care into this environment would fail if we didn't address this dominant culture. And we tried to, and we refined a model of training health workers over time called The Secret History. It is loose, and I've mentioned it in various departmental meetings over the years, but it is loosely based around Augusto Boal and Paulo Freire's theatre of the oppressed initiative or process, whereby ordinary citizens or partakers, people who partake in a political process or are victims of a political oppressive process, are able to reenact that oppression and then reimagine different ways in which the situation could unfold that may be transformative and non-oppressive. And so we have written up this method. We have done small internal evaluations of this method, and it has in fact been incorporated into training across the country within the national maternity training programs offered by the Department of Health. And I'll give you a quick flavor of what it looks like from the films that we've developed to assist other trainers to provide this method. So I would like you, this is a quick snippet of a so-called disrespectful interaction that we encourage participants who are health workers to reenact. They're reenacting themselves as one reveals a story, the background story of a typical client and a patient and a typical staff member, where their secret history is revealed in stages, what's going on and the difficulties and challenges that each role player is facing in their lives, and then we encourage a disrespectful interaction.
You went until 7.
You
so
were
it's
till
not
7.
7
It's
yet.
off for 6 now. You've got the time. Just a second to go on, please. You need to wait for the night to come. This is and this blood everywhere. Sister, can you help me, please? I'm alone here. I'm so tired of this. I am tired of having to be mother to teenagers that is so irresponsible.
Sister, I know that it's almost time for you to go home, but that's not my problem.
Don't you look at the time?
Here now, after we have a discussion and a debriefing with the participants in the training, what are you feeling? What do you need at each stage of the story as it unfolds? We then have a discussion on what are the core skills on empathic care. We practice some of them, and then we reimagine another scenario, this time in a fishbowl style, where these skills are then practiced and the participants reflect on the impact of using these skills in terms of efficiency, effectiveness, personal satisfaction, and ethics.
How long has it been now? 6 hours.
Hours, yeah. They promised to help
While the
me.
pain is there, is it okay if I rub your back?
Yes,
And then
please.
we can have a chat once the contraction is over. Let me know when it's over, right?
Please help me.
Okay. How would you feel about moving about in the labor ward, trying getting up out of the bed?
But I'm very tired. I
We know
don't
that
have
it-
energy.
It does help to bring the baby down, to move, and to make the labor shorter.
But
Okay.
I will try, but I don't have energy. It's been a long time now. Oh,
It
but
does
now
help to shorten
I
the
can
labor.
try, I will try, but not now because
I see you're quite
no.
tired, eh?
Yeah, very
It's been a
tired.
long 6 hours for
Yes.
you.
Okay, so our training principles that we rest we rest upon when we develop training at PMHP is that it's an overlap of transferring knowledge. A lot of health workers have poor mental health literacy, and we need to impart basic mental health knowledge, but at the same time we need to look at capacity building and skills transfer. And linked to this is understanding the own mental health needs and physical health needs of health workers themselves. So when we integrate that into our training, we find that each of these components mutually reinforce the other. So if we're wanting this type of training to happen at scale, we have realized that working with a secret history is very, very dependent on skilled providers, and where these are not available, we have limited ability to scale. So what do we need in order to scale? We need a low-cost intervention which can supplement or replace the scarce resource of high-quality trainers. We need potentially to explore digital solutions, and here we need to harness smartphone capabilities. We need to also look at keeping this idea of game playing as a form of enhancing learning outcomes. And that is where, and also look at the benefits of digital storytelling. We realize that telling a story in training is very helpful. People use narratives, they use case studies. We use the secret history storytelling technique, and we need to optimize. If we are using digital solutions, we need to optimize engagement and interactivity. So this is what we thought about. These are the things that we thought about when we decided to take this training method and adapt it onto a training application. And in fact, we were approached by the Department of Computer Science, in particular, Professor Melissa Densmore, who's a key player in the SHiMA initiative, to take this training and to adapt it using a choose your own adventure framework onto a mobile app. We'd worked with Melissa and her team in various maternal and child health projects previously, and it was a great opportunity to explore another way of providing capacity building for health workers. Now, what is Choose Your Own Adventure? Many of you will remember these books. I think they came out in the 80s. Bantam Books started this idea of having a reader. These were books that were designed for teenagers, younger teens, or in particular, where they could be in their own adventure, they could take an active protagonist role, and they could make choices within the story to choose one approach versus another when faced with a conflict or a challenge. So if the ultimate goal, as you can see here, is to save your friend from the aliens, or to find out who killed somebody, or to discover the lost jewels, you would be taken as the protagonist, the reader, along an adventure. And when you came across a problem, you would have a choice to either solve the problem in one particular way or another. So if you came across a river, a raging river in between you and the lost jewels, would you either build a raft, negotiate with a crocodile to get a lift, or walk around the long way? And depending on your choice, you would go to a different page and the story would unfold algorithmically accordingly. So we took this idea, this CYOA idea, and we adapted it onto a mobile app with Professor Densmore and her master's student, Sharifa Nagesa, who's just submitted her master's on this work. And what they did is they helped us do the first phase of co-design of the app. They did a needs assessment. We built content together with them in a series of storyboarding workshops. And then they conducted 2 series of iterative co-design workshops of successive prototypes. And we reviewed and adjusted according to the outcome of those workshops and the pilot deployment with private sector maternity staff. So it was a long process, and we ended up with a series of stories that we had adapted into this Choose Your Own Adventure platform of key typical scenarios or cases of women coming into a maternity health service who are the frequent victims of obstetric violence. And these are the stories, and we got an artist to design images of them. And we wanted to, what we wanted to do is map key domains of empathic care, which we sourced from the literature, against the learnings that each story would provide the user. And these domains were, as you can see, rapport building, respect, supportive environment, information and choice, listening and communication approaches, standards of obstetric care, confidentiality and privacy, managing violence and non-cooperation in the client, and empowerment of the client, as well as self-care. And this is where we integrated our third pillar on self-care. And this is what the storyboard algorithm kind of looks like. It's difficult to follow. This is the first of 2 approaches. You can see similar to the secret history, we start off using pronouns, second person pronouns. You are sister-in-law, or you've had a very busy shift and you've a sick child at home. And then Pumeza is the 16-year-old. She's alone and crying loudly in active labor, which is progressing very slowly. And here is the choice. What do you do as the health worker? And there are 3 options that you can choose from, each resulting in a different consequence, both in terms of the client and in terms of how you're feeling. So, and we map this against a very poor, kind of medium, and a good possible outcome. And then the story unfolds. We stop the app along the way, and we stop the flow of the story along the way, and we ask the health worker, who is the user imagining themselves as the health worker, what are they feeling and what do they need? And we ask them to imagine what they think the patient or the woman is feeling and needing at the same time. And then we ask, what are the options? What should you do? And again, there's a good choice and a bad choice. And then there's a result. At the end of this flow, there's a reflective process where people are able to tick what empathic skills they used. So they self-reflect on what the skills were that they used to get to a positive outcome. And we encourage people to re-loop through the story and explore different pathways to get to the positive outcome. versus the negative outcome. So it becomes a sort of mutually reinforcing process. The interface we decided to use was the ComCare platform, which is used very widely in low resource settings, mainly as a monitoring tool for community health workers. But for several reasons, we decided to work on ComCare. We had a menu of options of the different stories, and then you would go into the story. And this is what the interface looked like. And you would tick the options of how you were feeling or how you imagined the patient would be feeling. We had various icons we used along the way to depict what the patient might be feeling, what you might be doing, what you might be thinking, and what the outcome might be. And those were standardized. I think the important thing just to mention is that at the end of the story, there was an option to go into a resource repository of extra information on the empathic skills. So if you wanted to know more about reflecting feelings or more about knowledge sharing or more about creating rapport, you could click in and have access to a lot of the PMHP materials and videos that we've developed, which expand on those features. There's also an option to click into a self-care process, and self-care activities were embedded in the stories all the way through. We wanted to do a pilot feasibility study at Mowbray Maternity Hospital, which was an uncontrolled pre-post study with nursing and midwifery staff to assess how feasible the research procedures were, but also mainly to assess the feasibility of the app with respect to acceptability, demand, implementation, practicality, adaptation, integration, and expansion. And we also hope to assess the preliminary efficacy of SHiMA with respect to empathic skills, respect for maternity care, and self-care. And this is what our consort diagram looked like. We unfortunately ended up with a very small sample, despite enormous attempts to keep people enrolled in the study and for them to be retained from baseline up into and including the 2 follow-up data collection points. And this was a real pity because we ended up with a very small sample who completed all 3 data points, and we have some reasons for that, which we don't have time to discuss now. But so just to note right before we present some of these findings, is that there were severe limitations of the study. We had a very small sample size, which impacted the statistical our ability to do any statistical or inferential statistics. We are only able to do inferential statistics in terms of efficacy. And our research was limited to 1 facility with only 1 cadre of health workers, which limits the generalizability. We also realized that the platform that we had chosen had a lot of technical constraints that impacted our ability to fully assess how the participants engaged. And we weren't able to really get the back-end data that we were wanting to, and we had assumed we would be able to get because of a whole lot of technical issues around syncing, access to Wi-Fi, and an inability of the platform to track people's engagement unless they had synced their stories. There's various forms of bias that we are aware of. And these are, I suppose this is the most useful graph of our outcomes with respect to quantitative data. We asked 24 participants who'd attended data collection processes at baseline, about I think it's about 6 weeks into usage, and then another month to 6 weeks after that, so at the 3 time points. We asked these people who had been with us throughout the process to give feedback on the app along several domains. And you can see here from this colored graph that the option responses that are 5 indicate the most favorable responses, whereas the option response numbers 1 and 2 are the lower end of unfavorable. And so you get a general pattern. You can get a rough pattern here about the enjoyment of the app, how much people were interested, whether the app reflected reality, whether the stories reflected reality, how much people felt they learned in the different domains, self-care, RMC, empathic skills. And it was generally a favorable response, with most of the responses being 4 and 5. And then when we looked at our domain of RMC, or respectful maternity care, we were only able to find one tool in the literature that had been developed in low and middle income settings. It was in fact developed in Iran, and was a self-assessment tool. And we adapted this questionnaire, and you can see, and I'm going to go through this very quickly because this only represents a very small sample, but over time there was not very obvious changes in terms of improvement, both in terms of RMC knowledge and in terms of RMC practice. And then looking at the CARE tool, which we used, which is a consultation relational empathy tool, where we're looking at perceived empathic relationship. This is a tool which has 10 items with a 5-point visual analog scale. And you can see that over time, there seems to be a trend towards improved care or relational empathy. And then the ENACT tool, which is a tool that has been developed in Nepal, but also validated in South Africa. We use the South African version, looking at self-assessment of competency of counseling skills or basic engagement skills. There seems to be a gentle trend towards improvement over there. The SCAP tool is a tool that we spent a long time choosing, measures self-care practices of psychologists and similar professionals along various domains, physical, psychological, emotional, etc. And you can see that the scores did seem, in this case, to improve over time and overuse. So I would like to now, if this will not proceed, I'm going to proceed, allow Tyla to take over and speak about the more interesting qualitative investigation that we did with our participants. Thanks, Tyla, go ahead.
Thank you, Simone. With regards to the qualitative investigation, we facilitated 3 focus groups, which we had initially recruited based on the degree of app usage that was reflected in the ComCare backend. When we realized that the backend data wasn't accurately reflecting the usage of the app, we saw that come through in the quality of responses that the focus group participants provided. So it was actually quite a useful addition to have these focus groups because of the limitation of the technical side of the back end of the app. So over the 3 groups, there were semi-structured interviews with open-ended questions, and a number of themes emerged. The big one being the importance of training for health workers. And because the research study is intended to look at the value of this app for health workers, we wanted to look at the impressions of using the app, downloading it, that kind of ease of use, how the stories flowed, how that works for the health workers, and then the suggestions for improvement in order to be able to let it go to scale. So a thematic analysis was used, and there was quite a rigorous process with regards to dual facilitated facilitators and more than one research analyst, so that any kind of research bias could be mitigated against. And then you may go on, Simone, thanks. The next slide. So some of the findings from the focus groups are quite interesting. So because the secret history intends to be a training modality, the health workers really looked at the need for additional training to keep up to date with changing medical knowledge, looking at empathic skills training and the ongoing need for that. There was a mix of different cadres of professionals. So there was the need that to adapt theory into practice, and strongly, what came out very strongly was the need for self-care. Thank you. And when we explored the app installation and use, there was a mixed response with regards to comfort and ease of use. And this may be linked to a number of factors, phone comfort, age ranges, and different comfortable levels with phones. And then there seemed to be a poor understanding of the use of the app, that it was designed for offline use. It did not need data, which was reiterated along the data collection points. But the knee-jerk reaction is that we assume that everything on our phones need data and need to be online. And that was a big part of why much of the data wasn't sunk or synced to the back end for us to see. And then further findings was quite a diverse range of perceptions of the app. So on one side, there was the perception that was constructive criticism, in the sense that the app was relatively predictable and the stories weren't as realistic as we had intended. And then on the other end, many participants also felt that the stories resonated with them, that they were relatable, and they were positive. So some of the quotes that really allow us to expand on this is this first one on the screen. You will see that some of the reactions that the patients would have given your positive response to them, the way we designed it is that if you gave a positive response to your client in the story, you would receive a positive response from the client. But what the health workers highlighted for us is that even though you as the health worker would try a positive response, you might not necessarily get that initial positive response back again. So it allowed us to see the need for nuance and the need for greater enhancement of those storylines to be a bit more realistic. What was interesting is some people did play around to see what different responses you could elicit if you chose a different direction to move in. And then there's also some reflections that it was relevant, because what was nice to see is that some people matched it to how they would actually respond, and some people sort of tried a different reaction to see what that would look like. So, and then there was the dichotomy of either you were too bad as the nurse or too good, so that element of realism was missing in some of the stories. The storylines, there's 8 storylines. There's a pregnant teenager, a woman with HIV, a woman with multiple pregnancies, a woman who is a sex worker, a woman that's exposed to domestic violence. But the stories, according to the staff, needed a little bit more depth, and it needed some more topics. So a lot of staff spoke about substance use, perinatal loss, long-term hospital stays, and more nuance with regards to psychiatric clients. This may mean that it could work better for different levels of care. So primary facilities might be exposed to a certain type of client, secondary and tertiary might be exposed to different patients, and then the stories can then match that level of need. With regards to how and why people were using the app, many people just said they browsed through the stories, there was the curiosity about the stories, but with regards to limited time, people sort of rushed through. And then with regards to, no, you can go on, it's fine. So because this is the big question of how useful is the app as a training model or a training supplement, many people really leaned into the resource section of the app, as it was embedded in the stories, but you could also access the resources without going directly to the stories. So many people really enjoyed the resources. It connected to very basic empathic care. So it was reflective listening, communication, how you communicate care. The design and layout was a little bit, wasn't a fan favorite. There was one person who said it looked a little old-fashioned. So, I mean, it helps us to see what's going to be most receptive to our audience. And then the big one was the self-care. Many of the healthcare workers reflected positively on the self-care elements. There was a desire for more self-care elements and a little bit more interactive elements of the self-care. So it really leans into what happens systemically with regards to obstetric violence. It's often not that health workers are intending to be horrible, that there's often a burnout, and you project that burnout onto your patients. So the embedding the self-care element really drove that point home of trying to address the obstetric violence in that way. Thank you. And then the behavior and attitude changes. It's interesting to see some women spoke about how they were noticing becoming more introspective about how they were engaging with themselves, clients, and colleagues. And there were sections of the story that affirmed the helpful behavior that many healthcare workers may have already been doing and maybe weren't aware of. So that sort of validation also helped them lean into the behavior and attitude change, because it wasn't necessarily a reprimanding process, but it was a lived experience that you could see yourself reflected in. We can move on. And then this was our favorite part, the suggestions for improvement. We got some story suggestions for improvement, but also layout suggestions. There was a big request that the app not be only for nurses. I think there's a perception of bad nursing that they were wanting to sort of move away from, that it's not only the nurses, but it's the healthcare system altogether, and that other cadres of professionals could benefit from it. Because it's mainly text-based the way the story unfolds, there was a request for audio and video elements within the app, a little bit more depth into what the story might be about prior to clicking on the story, so that if you have a particular interest, you can maybe see, okay, the story attends to substance use or it attends to teenage pregnancies, and if that's your interest, you can focus on those. There was also a curiosity around it being a little bit more responsive and more interactive, almost as if it can be a repository of Q&As where you input your request or your concern and you get feedback, either a story that matches it or a resource that matches it a little bit quicker. Because with the interface, you have to sort of scroll through many different things to get to a resource that you might enjoy. So there was this request that maybe there's a search element that you can narrow down your focus. There's the ultimate desire for face-to-face training, that staff still enjoy the face-to-face element for what it provides, and that the app could maybe be a supplement to it, that it's almost your little repository, your network that you tap into when you need it. So face-to-face is still for the win, but we've noticed those as well. So the recommendations include notifications that is a reminder that the app is for free and you can use it offline. Other recommendations with regards to inputting your own feelings and your own thoughts, because there's just a list that you can choose. So some of the health workers wanted a space to add your own interests and your own needs. Expand the stories with a little bit more nuanced responses and character development. The chatbot format is quite interesting, as many of the healthcare workers were interested in that. And the validation and mentoring section came up as well, in that health workers want to be able to see if what they are doing is working and what must happen differently. And then the audio elements, but also more self-care materials. And then the health workers were not happy with the common care platform. So we were taking that quite seriously. And then just our list of acknowledgements at our funders are Innovation Edge, Sharifa Nagesa, our master student, Melissa Densmore, that's offered us brilliant tech input, and Pelegi Emma McKinney, myself, Sally, Antonia, Jason Marcus, Catherine Sorsdal, the co-design and study participants and the assistants, and then Mowbray Maternity Hospital for all the hospitability to allow us to engage with this kind of sensitive material and give us this kind of wonderful insight. Thank you, everyone. I think there's still a little bit of time for questions. I was zooming through it so that we could still have a bit of discussion at the end.
Thank you so much, Simone and Tyler, for a very innovative presentation. I think that I'm quite amazed at the resource tool that you have used in actually accessing mental health care workers, especially nursing. And I think that for me, that stands out. I have one question to ask. So I know that, considering we all know that the healthcare system is quite overwhelmed, overburdened, and I think that comes through around the burnout and the reminders around self-care. And it's amazing that you were able to get a set of nursing that could actually allow their time to be in this. But I think that it's a continuous struggle to actually get the work out there and have people involved, not because they don't want to, but because oftentimes there is no replacement of staff to do that. And I think that initially when I had heard about obstetric violence, I immediately thought about, if we think about intimate partner violence and gender violence, we think about power and control. And that was my perception initially as we were talking about this. And I got to learn that it's not just about that. It seems as though a lot of the disrespect and abuse is not necessarily because our nursing and staff actually does not have or wants power and control, but it's more broadened around skills and training. And so that stands out for me. And with that said, I wanted to know that in South Africa, are there legal implications around, on the act of obstetric violence, and what can happen in that context? I'm not sure if that's for you or if any one of you can answer.
I can answer to that. There is an ombudsman's telephone number that service users can use to register complaints, particularly around disrespectful care and abusive care in maternity settings. I don't think it's really well used or well staffed, that line. However, there are, we do know that a huge proportion of litigation against the health system occurs, if you unpack and decode what's happening in those legal cases, a lot of that can be attributed to obstetric violence. So increasingly, service users and their families are taking the Department of Health to court over cases of obstetric violence, and there is a huge legal expense to manage those cases. So that's the kind of sad news. But the good news is that the maternity care guidelines, which have been drafted now for 12 months, the new maternity care guidelines, have not been signed off by the minister. I think there's been a lot of changes in senior level within the ministry, but the new maternity care guidelines, which are now the first version since 2016, so they've been really outdated. We've been working with really outdated ones. The new guidelines now have a chapter both on mental health and on gender-based violence and on respectful maternity care, which we were lucky enough to lead the writing of. But now that it's in, as soon as the guidelines are signed off, these are the documents by which the providers of the Department of Health and the provinces are obliged to adhere. So these maternity care guidelines are the ones that stand up in court. And for the first time, there are key stipulations around what is and isn't acceptable behavior. So yeah, I hope that answers your question on accountability.
Definitely. Absolutely. I think that is amazing to be able to drive that force in getting it updated as well. And I think that in South Africa, we have good legislation in place, but oftentimes a lack of implementation. So I'm hoping to see at least that these oversight bodies are taking it a lot more serious, considering the levels and the statistics on violence. Yeah. Can I just check with the team? I mean, our colleagues, anybody have any questions?
Martha has a question, I think.
Okay, I can't unfortunately see my screen, so please go
That's
ahead.
fine.
Yeah, hi. I'm Penka, and I am not probably part of this team. Yeah, I got the invitation from Prof Simone because I am his student. I'm doing my PhD on storytelling and in the sector of pediatrics. Yeah. So I just want to say the presentation was really interesting, and I was interested in seeing because I think one of the challenges you mentioned was that some people felt like the stories were not realistic, and yeah. So my concern is how was that addressed, and what is the ethical considerations? Because I am also having that challenge in my work where I am more interested in, I believe that the lived experiences shared in the first person point of view, like it is my story, is very useful and very impactful in terms of behavior change. But then there is that issue of ethics where you get to see the storyteller, where you get to know the storyteller. So I am keen. I don't know if you've had that experience and how would it address the issue of ethics and how can we ensure that the stories are more realistic? Yeah. Thank you.
Tyler, why don't you go ahead on that? I mean, yeah, go ahead.
I thank you, Martha, for your question. I think I'd wait to see how yours unfolds as well. A big part of what we noticed with the healthcare workers is that the third person narrative was helpful, and sort of being in that person's shoes was helpful in the sense that it's a little bit separate to who you are directly, and there is that opportunity to then play around with what that story unfolds. And then because of that degree of cognitive distance, you're able to connect a little bit more with the story. I think sometimes when it was in a first person narrative, it's a little bit more vulnerable. What was interesting with some of the participants, they mentioned that if there's audio, you would essentially be listening to the story, and you would listen to the person's cadence of their voice and how they land on different nuances and tensions in the story, and that might be a little bit more easier to connect to as opposed to text-based. So I think different elements of how you're putting the story together might also allow you to lean into that lived experience a little bit more without impacting ethical considerations of privacy and confidentiality. So creativity in terms of how the story is told lands well, and the third person narrative of you are Sister Ndlovu or you are Sister Beatrice allows it to be a little bit of a performance connected to that experience, because you might notice someone who is similar to this, but it's easier to see it in the third person. That's what we noticed with the healthcare workers.
All right.
Thanks, Tyler. And just to follow up on that, I think almost half of the group that we spoke with said these stories were too extreme and unrealistic, but half actually said they completely resonate. And the stories, so I think there were differences of opinion. And when we spoke with respect to the stories of the patient or the client, we amalgamated from our own experience and understanding, from our own exposure over 20 years to the typical scenarios. So they're not a direct lived experience rendition of a story where somebody shares their story, which I think I agree with you might be very, very powerful, but there are an amalgamation of real life stories. But go ahead, I think you want to say something.
Yeah, I want to say, I totally agree with what you said, and I am still at the early stage of my PhD, so I'm just at the proposal stage. Yeah, and I don't know if the work is already ready to be cited, or how can I get, a little bit engaged with what you're doing, learn a little bit more, and also let you see what I do, if that's possible.
Please, let's connect and we can tell you about that.
Okay.
I'll type my email into the chat.
Okay, perfect. Thank you.
Thanks, Martha.
Thank you for your question, Martha. I'm sure there's a lot more questions. I mean, I'm sitting with still a few more that I'd like to know, but I think for the sake of time, we have to end, unfortunately. And so I want to say thank you to both our speakers for sharing SHiMA with us. And, you know, I'd like to know a little bit more around that name itself, you know, but I think that thank you for allowing us to know the secret as well, you know, and I look forward to actually having a more enhanced technological kind of innovative study like this in future. It sounds like there's a lot that's being done about it in terms of monitoring and evaluation, and with the lessons learned in how to improve and to adapt it further. So thank you so much for sharing that with us. Thank you to all participants that have attended today's lecture. Please join us next month with the Division of Psychotherapy. Prof Simone was speaking to us on suicide. Thank you so much.